Good morning to everyone, and thank you very much. Welcome to the session. This is a fireside chat on what is the best approach to stem cell transplant in DATA2. Very excited to present two excellent speakers who have kindly agreed to join us. We have Dr. Jennifer Conakry from the National Institute of Health and the NCI. Dr. Conakry has engaged in clinical research for allogeneic stem cell transplant activities for patients with primary immunodeficiency, inherited and acquired disorders of T cell proliferation, and has taken care of patients with DATA2 and has agreed to present her view on the best transplant strategy. And that will be followed by Dr. Isabel Metz from the University Hospital in Leuven, Belgium. Dr. Metz really heads the primary immunodeficiency research at the university. She leads a laboratory for inborn errors of immunity at KU Leuven and has spent a lot of time focusing on ADA2 deficiency, unraveling the genetics and pathophysiology. And so this is very, very exciting. I would like to start off with inviting Dr. Conakry. Please take it away, Jen, and thank you for doing this.
I'd like to thank the organizers for inviting me to talk about the best approach to allogeneic hematopoietic cell transplantation for DATA2. I'm Jennifer Conakry, and I'm a clinical researcher within the Experimental Transplantation and Immunotherapy branch of the National Cancer Institute at the NIH, and I run clinical trials of allogeneic transplant for patients who have immune disorders as well as hematologic malignancies. When I think about any patient who needs a transplant, I consider several factors related to the patient and his or her disease, when and if that patient may need a transplant. I do like to also start thinking about donor options early, as this may take time, particularly if options are limited and if genetic testing needs to be done of donors in preparation for transplant. And as I consider the transplant approach, I think of the conditioning, the graft source and its manipulation, and GVHD prophylaxis as sort of separate entities that can relatively independently be modified or changed to create the optimal transplant approach. And because transplant is not an off-the-shelf therapy, it does take time. I do like to plan ahead when I find any patient in consultation that may need a transplant. I start thinking about donor options ahead of time, because the reality of transplant is sort of the second panel of this cartoon, where there are many hurdles along the way that may slow the journey to transplant. In general, the goals of transplant are to get it right the first time, and to do that, use the lowest intensity and lowest toxicity possible to be successful. And in DATA2, I think a successful transplant means that the patient has engrafted with both myeloid and donor T cells without having significant organ toxicity. And we think a lot about veno-occlusive disease, sinusoidal obstructive syndrome in DATA2 patients. Avoiding life-threatening infections, avoiding graft versus host disease, and especially chronic graft versus host disease, which could potentially change them from having one chronic inherited immune problem to another chronic acquired immune problem. And then as I think of the transplant approach, I envision the potential long-term consequences of that approach, where the intensity of the conditioning, as well as the inclusion of radiation and other factors, can increase or modify the risk of long-term consequences like infertility, secondary malignancies, growth retardation, cognitive issues, heart disease, osteoporosis, thyroid disease, etc. And where a successful transplant in DATA2 ultimately means that the patient achieves phenotype reversal and no longer has evidence of their disease phenotype. And in addition, hopefully has robust immune reconstitution and goes on to live a relatively normal life with a healthy immune system. I've separated out here some considerations regarding donor options, transplant approach, and disease factors, and I'll go through each of those in turn. One of the first things that I say to patients when I meet them for transplant is that they have to have a donor. They can't get a transplant if they don't have a donor, and that donor, of course, has to be eligible and suitable and willing to donate. We often think first of having fully matched donors, either using the unrelated donor registry or picking among full siblings, but each full sibling only has a 25% chance of being a full match, as we all know. And many patients, actually the minority of patients, will actually have a fully matched, unaffected sibling as their best donor. When we think of alternative donors, there is cord blood as well as HLA haploidentical family donors. Cord blood is obviously limited in that it's a fixed dose and that there's no chance of getting a second cell product from that donor. And I do think that this is an important consideration in DATA2, where graft failure and mixed chimerism can be an issue, where you might want more donor cells from the same donor as the original transplant. And then, of course, for adults, cord blood can often yield relatively low and sometimes insufficient graft doses, and there is an increased risk of graft failure and delayed engraftment. So it may not be the best donor source for DATA2 patients, but it does remain a potential donor source, particularly for patients of minority ethnic heritages. Similarly, haploidentical transplant may be a donor source for patients who otherwise don't have matched unrelated donor options or related donor options. Parents and children are by definition going to be haploidentical donors, but they also will be carriers in the setting of DATA2. And siblings can also be haplodonors, and they might be carriers. But again, parents and children will definitely be carriers. Here at NIH, about a year ago, we looked at all the patients who were referred to transplant for primary immunodeficiency diseases and the outcomes of both the related and unrelated donor search. And in that study, there were 8 patients who were referred to us for transplant for DATA2 who underwent an evaluation of donor options. And for those 8 patients, the best related donor option was an HLA haploidentical donor for all 8. No one had a matched sibling that was a suitable donor in the mix. 4 of those 8 haplodonors were over age 50. And so not surprisingly, 7 of them were parents, and all were carriers of ADA2. As far as the unrelated donor searches, the MUD searches, 4 had good or very good MUD searches, but 1 had a very poor MUD search, even though that patient is of non-Hispanic Caucasian heritage, which would suggest faring well in the unrelated donor search registry. And 2 had a fair search, which may or may not yield an unrelated donor that is actually able to provide a graft for transplant. So my take home from this would be that in considering transplant for DATA2, you should be ready to use a haplodonor. You should be ready to use a carrier donor, even though we still are not fully clear on if a carrier is a good donor option, although carriers have been used in DATA2 transplants. And to be ready to use an older donor, such as a parent. And these are often donors that we don't typically think of as our first choice or even our second choice when we think about transplant for immunodeficiency diseases. As far as the transplant approach, there are several aspects that I think about, particularly when I think about DATA2 transplant. First is the intensity of the conditioning, where the patients that go to transplant for DATA2 are typically those who have T-cell mediated immune cytopenias. And so by definition, what the disease requires to get rid of it is a transplant approach that intensely lymphodepletes the host and these very resistant host T cells that are pathologic in the disease. And that doesn't necessarily equate to the intensity of myeloablation, although that's how we typically think of transplants, sort of graded on the intensity of myeloablation. As a reminder too, both reduced intensity and myeloablative approaches have led to successful outcomes of transplant in DATA2. With regard to intensifying lymphodepletion, serotherapy, which includes alemtuzumab or Campath, as well as ATG, both rabbit and horse, can be of benefit to patients who enter transplant with non-malignant diseases. They typically haven't had lymphodepleting chemotherapy prior to transplant. And patients with DATA2, I do think, can be especially hard to engraft. And so serotherapy can serve a nice role here where it may help during conditioning to eradicate resistant host T cells that are causing the immune cytopenias. But it has to be used well, because if it's used in a way that too much bleeds over into the graft, then there are long-term and short-term issues with immune reconstitution, infection risk, and you have to find that right balance of where to put the serotherapy so that you optimally lymphodeplete the host, but really don't chip away at the quality and function of the graft. With regard to alkylator choice, most transplants for DATA2 are going to include an alkylator. And so it's a question of if treosulfan is available, as that may be associated with less toxicity, although long-term data related to fertility and other long-term outcomes are still pending for treosulfan. With regard to busulfan, because it does readily cross the blood-brain barrier, if a patient has previously had seizures or has an active uncontrolled seizure disorder, that may be an issue, and that does remain a consideration as we think about how a DATA2 patient might tolerate transplant. And then, of course, what is the busulfan pharmacokinetically dosed, and how is that done, and is that done as optimally as possible? As far as graft source for DATA2, I do prefer peripheral blood over marrow and then over cord blood. And this is a little bit different than what is preferred often in general in the field of transplants for primary immunodeficiency diseases, because marrow is associated with less chronic graft versus host disease. But I do think that there is a benefit in hard to engraft diseases as long as the graft versus host disease approach is good to use peripheral blood to try to overcome some of those early engraftment issues. As far as the graft versus host disease approach, there should be an approach that includes the use of haplodonors, because as I've said, you really should be ready and able to use a haplodonor if that is the best donor option. And also, when we think about graft versus host disease prophylaxis, we should think about what we really want to ideally prevent. Chronic, I think, in this disease, you really want to prevent chronic, but maybe should we tolerate some degree of acute graft versus host disease to really burn through any residual host T cells that may threaten the graft stability and the reversal of phenotype. The other major thing to consider is, where is the transplant going to take place, and what are the resources available at that transplant center? And I think this is really in DATA2 maybe as important as these other factors that I've discussed, where you need to be able to coordinate care between transplanters, rheumatologists, immunologists, and the other specialties, including neurology, dermatology, hepatology, nephrology. You need to have a strong transfusion medicine department and department of laboratory medicine. I really think that to transplant DATA2 patients, you have to have a lab that can assess T cell chimerism, not just whole blood or myeloid chimerism, but T cell chimerism serially with a reasonable turnaround time on the order of days, not a week or 2 weeks. I think it should be a transplant center that can do haploidentical transplants. And I think it should also be a center that has access to serotherapy apart from rabbit ATG. As far as patient factors, we do know that younger patients fare better with transplant. They often have less comorbidities and less sequelae of their underlying disease, but it's understandable that they may not feel ready to take on the upfront risks of transplant. And this is a common scenario throughout transplant for primary immunodeficiency diseases, where by the time everyone involved in the care of the patient and the patient themselves decides to move forward with transplant, we all sort of feel like we wish it had happened a little bit earlier. And so we think specifically about each patient's organ dysfunction and infectious issues going into transplant to, again, inform the approach to transplant. And I do think in DATA2 biopsies are very important. You have to look at the marrow. You have to see how infiltrated it is with T cells and where the maturation arrest of hematopoiesis is occurring. And I also think it's important to assess the liver potentially with a pre-transplant liver biopsy. And we have transplanted patients who have had normal LFTs, normal liver ultrasound, and on pre-transplant biopsy had sinusoidal dilation and perisinusoidal fibrosis, who actually post-transplant developed veno-occlusive disease. So that leaves me with some questions for everyone that remain for DATA2 transplant. Is a complete myeloid graft requisite for cure? I think potentially not, although desired. Is a complete T cell graft requisite for cure? I do think yes. As I threw out there earlier, should we tolerate a little bit of graft versus host disease early on to burn through residual host T cells potentially? Are all carriers equivalent as donor options? We really don't know how to assess this if faced with only carriers as potential donors. And should we transplant DATA2 patients earlier in their disease course? So with that, I would like to thank you for your attention, as well as the patients and their families. It's an incredible group of patients with DATA2 who we have transplanted at NIH. We haven't gotten it right on the first time, and all of our patients and the patients and their families are incredibly understanding and willing to participate as we try to further the field. The DATA2 Foundation, and then all of my many colleagues at NIH who work to help us transplant DATA2 patients to the best of our ability. Thank you.
Oh, that was fantastic. Thank you so much, Dr. Kanakri. I would now like to invite our next speaker, Dr. Isabel Metz, who's going to give her perspective on what is the best approach towards allogeneic stem cell transplant in DATA2. Thank you, Dr. Metz. Please go ahead.
Thank you very much for the kind introduction. And also thank you very much to Chip and to the organizing committee to invite me to discuss with you this difficult issue. I'm going to discuss with you actually the findings of a recent survey on stem cell transplantation in ADA2 deficient patients around the world. And it's very recent data, so some of the analyses are still ongoing, but I think it will reflect in a way all the questions that have been raised by Jen in the previous talk. So if I can go now. So indeed, as we saw, it can be a very bumpy road, this transplantation in ADA2 deficiency. And the first question is indeed setting the indication. It's really a balancing act. We know from the literature that ADA2 deficiency has a mortality of around 7 to 8%, especially at young age, with mean age of that being 15.2 years due to vasculitis and complications of immunodeficiency. We also know and learned in the previous days that hematological complications of DATA2 respond very poorly to anti-TNF and the other usual immunomodulators. And we know that ADA2 is mainly expressed in monocytes, though we learned about endothelial cells also. And so that will pose an extra challenge to what we will be discussing. And we know from the previous overview study with 14 patients. So looking into this, so we had 14 patients there in the cohort, all alive and well post-transplants, published in 2017. And as you can appreciate from the graph, actually almost all patients did well and were off immunosuppressives and off immunoglobulin substitution with a mean follow-up of 18 months with a range from 5 months to 13 years of follow-up. So importantly, we could raise the question, is this just too good to be true? And therefore, I think it was important that we went on to have this new survey, which we actually started in the summer of 2019 via an Excel file, actually gathering all the data on ADA2 deficient patients receiving transplants and out of transplant for more than 5 months, and having a molecular or enzymatic or preferably both diagnosis of ADA2 deficiency. So far, we have data sets on 28 patients available, mostly complete, and some info on 2 more patients. So we know we have 28 patients from 11 countries. So what about the demographics and the characteristics of these patients? So the median age at initial presentation was 2.5 years, which is actually in range with what has been published. And the median age at genetic diagnosis was 12 years. As presented in the previous day, so the most frequent allele was the R169Q, followed by G358R in 4 of 27 patients. And so the enzyme activity test level has been tested mostly by dried blood spot analysis, plasma spot analysis in Mike Hirschfield's labs. And I think it's important that we thank Mike for being so available to test all these patients. So what about the demographics then and the characteristics of these patients? So importantly, 3 of these patients had CNS hemorrhage prior to transplant, and 3 had had an ischemic stroke prior to transplant. And so as you can appreciate, most of the indications were actually set for cytopenia, and several of these patients actually had pancytopenia or a combination of neutropenia and puret cell aplasia. There was also the feature of recurrent infections, mostly viral in these patients. And I want just to highlight this, the reported splenomegaly reported in 21 of 28 patients. 27 had been on immunosuppressive treatment and were still on immunosuppressive treatment while going into transplant, mostly prednisone and cyclosporin A. And 12 had received anti-TNF prior to stem cell transplant, mostly the ones with offered CNS vasculopathy or other vasculopathy signs. 6 patients were on G-CSF without any response or any remarkably or sustainable response, and 14 were on immunoglobulin substitution. So the indication, as said, was really bone marrow failure in one or two lineages and immunodeficiency. So the median age of transplantation was 9 years of age, and I immediately go here with you to the final, let's say, the outcome slide. And as you can see, most of the patients, except for one, sadly, are actually alive and well post-transplant and are almost off any supportive treatment, except for some on immunoglobulins. Those were receiving rituximab as part of the conditioning or post-transplant for EBV lymphoproliferation. So 27 out of 28 are alive and well, as said. And the median follow-up here is 48 months, which is longer than in the previous study, with 5 months as the shortest and 16 years the longest. Engraftment was pretty steady for most of the patients. As Jen alluded already to, it's very important to watch for veno-occlusive disease, and 4 out of 28 developed veno-occlusive disease. 3 of those 4 received busulfan or cyclophosphamide in our TBI in the conditioning regimen. And an important feature is also that viral reactivation was quite common, with 15 of 28, mostly adenovirus, and all received, actually, the ones that had adenovirus reactivation all received serotherapy. Sadly, so as I told you, 1 patient died. This was very early on post-transplant at the time of a parainfluenza virus pneumonia, and this patient also developed VOD and a capillary leak syndrome. This patient had received a 9 in 10 matched unrelated donor with flu-bu and alemtuzumab and rituximab as a conditioning, received bone marrow, and a MMF, CSA, and post-transplant CI as a GVHD prophylaxis. We also have to mention, so I presented this patient in the talk on Tuesday. There was 1 late onset liver disease where there had probably been silent liver disease, as Jen mentioned, and now developed actually 9 years post-transplant nodular regenerative hyperplasia. Important, and I think that's the main obstacle here in stem cell transplant for ADA2 deficiency. There were 36 transplants for 28 patients. So absolutely important to try to focus on this. So why is this graft failure happening? So I thank Hassan for having made this slide and to have analyzed it just now. So we can appreciate there was one patient who actually had insufficient cell dose at transplant with only, I would say, 1.4 million per kilogram CD34 cells. And so this patient immediately received another stem cell dose. This was a patient transplanted by Dr. Hickstein. There was actually 2 patients transplanted with their matched sibling donor, who then later was found to have the disease. So they went on to have a MUT and are doing well. And then there are several patients with need for 1 or more retransplants or unconditioned boost. And as you can see here, there is no really consistent feature of these patients. What is really the problem? So most indeed got bone marrow as a graft source and not peripheral blood. And you can also see that there was use of alemtuzumab or ATG, but it's not really clear what we can derive from this. So to come back to the idea or hypothesis that it could be potentially the donor T cells that are a problem here, I can show you here that not all of the patients actually had an incomplete or a very low donor T cell chimerism. So another patient, the info that we received from Paulina Stefensky, actually received a stem cell graft from a carrier of a pathogenic variant. And I think that's very important. And this patient went on to have another transplant, also with a quite heavy conditioning regimen, developed grade 4 gut GVHD, and also sadly passed away. So this patient was not included yet in the 28 patients because we don't have the full data set available. But so we end up with 1 more patient sadly dying. So what's behind all of this graft failure in this condition? So one hypothesis indeed raised by Jen, are the host T cells residing in the bone marrow a cause for this problem? And because it was noticed in the NIH cohort that there was low T lineage donor chimerism below 10% in those suffering graft failure. But actually some other patients went on to have graft failure without very low T cell chimerism, because actually this is some sort of the level that we would be quite happy with in some of the severe T cell conditions. So, and this is actually a graph that is from a paper that we published in 2017, where we actually followed serial levels of cytokines, inflammatory cytokines and chimerism in a boy that we transplanted. And so here you can actually appreciate the ADA2 plasma enzyme activity that all of a sudden starts dropping at the point where the total blood chimerism drops to 30%. And at that time, you can also actually see that the interferon alpha in the blood is again rising together with IL-6. So it seems that the drop in myeloid chimerism, at that point, the donor T cell chimerism was still 100%, actually provokes an important drop also in the graft and in the graft function. Some other feature just to highlight, because nothing is really, let's say, significant in this analysis. And here we analyzed all the patients. And actually, when we look into the entire overview here, there is not much that we can derive. We can only say that it seems that therapy is in one way or another important in these patients, so that it is true that serotherapy seems to play a role in sustained graft and sustained engraftment. This is kind of a skewed picture because, of course, if you have one haplo that works well, then of course it seems like the best donor. But overall, we would say that a MUT or a mismatched MUT seem to be good donors for these patients. And here, of course, there's the bias of the diseased and the carrier sibling donors. And in terms of conditioning, there's maybe one thing that we can derive, and it seems that the cyclophosphamide-containing conditionings are a little bit harsh for these patients. But again, if we would have more data to support this, it would be good. So indeed, it seems like maybe the myeloid chimerism is not that important, and we need to focus more on the immunoablation. We looked at the effect of GVHD prophylaxis. It's quite complicated and we cannot really conclude anything, except you see here all the stars or post-transplant CI. It doesn't seem to be, let's say, the ideal choice in these patients. So conclusions and perspectives. So it looks like stem cell transplant can be a definitive treatment, sure, but there's many buts. As you can see, if we look at all the patients that we know of from literature, and also some collaborators and some people that I contacted during this meeting, we would have like 34 patients of whom 2 passed away, sadly, with 95% survival overall. But so these are the questions that are remaining. I would say splenectomy, yes or no post-transplant, maybe opt for another donor if there's graft failure, and maybe test even the MUTs for ADA2 carrier status if that would be something that we could accomplish. Be careful with the liver, as Jen said, and indeed monitoring and preemptive treatment of viral infections. And that's about it for me. Thank you.
Excellent. Thank you so much, Dr. Metz and Dr. Kanakri. These were excellent presentations, and now we have a very exciting set of questions that have been posed. So I will read them off and request you to answer them. The first question that is here is for Dr. Kanakri. Any thoughts about bridging therapies while awaiting transplant or for donor matching, specifically with regards to TNF inhibition, JAK inhibitors, or cyclosporin? Your thoughts on that?
So, the patients going to transplant, it's typically for cytopenias, and so often they'll be on steroids or cyclosporin or some other immunosuppressive. I think, being on a TNF inhibitor and having good control of the other manifestations of DATA2 is likely helpful as well, and although some of the patients that have been referred to us come to transplant because they don't want to be on those types of drugs and other things, but like all patients going to transplant for immune deficiency, it is helpful to use that time as you're finding a donor to try to optimize their overall condition, but of course you don't want to be introducing risk of new infections or toxicities. So it's a balance.
Excellent, thank you. And another question again for you, Dr. Kanakri. What are your thoughts about transplanting patients with severe loss of function mutations very early in infancy, especially if they have an older sibling with a very severe phenotype?
So, yeah, I don't, that's a hard question. And I wonder what Isabel thinks about that too. There are many immune deficiency diseases that we know can be quite bad, and know that family members have died at a young age or have very severe phenotypes. But it sort of remains in the field that for many of these diseases, people do not want to submit their babies yet to upfront transplant. We continue to need to make transplant safer so that we can entertain these ideas more readily and make transplant better. But for DATA2 patients, I don't think it's unreasonable to consider, but the majority of patients and families that I meet would probably be wary of that approach.
Excellent, thank you. The next question is for Dr. Metz, and this is from Dr. Grayson at the NIH. GCSF can trigger myeloid-mediated inflammation like Sweet syndrome. Did any patients with DATA2 have worsening inflammatory features due to GCSF therapy in your experience?
No, this was not a feature that was neither reported nor actually seen by myself in the patients that were treated here with GCSF. But I understand the question. It makes a lot of sense. And I'm also weary of using that drug in these patients. But in some patients, it helps. So I think it's always a relevant trial to, as you say, maybe bridge to transplant and find another cure or another definitive treatment. But we haven't seen it, sorry.
Oh, excellent, thank you. Dr. Kanakri, could you just walk us over how you go about screening related donors, whether it's for matched sibling or haplo in a patient with DATA2? So what testing, in terms of genetic or measuring the enzyme activity, what is your protocol in place?
So I'm fortunate to be at the NIH with a great group of folks who send the data to patients my way, and often have already done the genetic testing. We don't the transplant group doesn't handle any of our genetic testing, but of course, the sooner that information is available for a family, the better from the standpoint of a transplanter, because when someone approaches me with an inherited disease that needs to be transplanted, my first question is, who are my donor options? And I want to know where we're at with the genetic testing. And so I think it's the type of thing that makes sense to just get it done early and figure out both the genetics and the HLA typing, so you sort of know what your options are right off the bat. And that can be done through a variety of efforts, but it should be one of the first things that gets done, because it just adds time to getting to transplant. You don't want to be thinking of all of this as you have a patient with an ANC of 0, trying to get to transplant.
Excellent, thank you. Dr. Metz, this is a question from Dr. Dalal. What preparative regimen would you suggest if there is no good matched unrelated donor? That's question one. And question two, as a follow-up, is would you prefer a mismatched unrelated donor versus a haplo-identical transplant?
It's a difficult question. I would generally prefer a mismatched related donor to a haplo-identical donor. And the optimal conditioning regimen, I think the jury is absolutely still out there. But I also like sticking to, as I call it, my protocol, because if you know your protocol, you know all the regimen toxicities very well. And I just try to adapt it a little bit by, as Jen also said, trying to either give somewhat more serotherapy or a little bit earlier, or just play with the little details of the conditioning regimen. But I think for ADA2 deficient, it's very hard, and we really need to have more data and maybe come up indeed with a protocol that we all adhere to learn more, because there's so many variables in these analyses that it's almost impossible to make any firm conclusions.
Excellent, thank you. The next question that we have is from Dr. Vlachos. So Dr. Metz, in the data that you showed, with the BuSci, were the doses truly myeloablative?
Yeah, so there were 2 very early transplants, or 3 even, where there was no BU monitoring. There was even oral busulfan, but all the other BUs were actually with pharmacokinetics and were targeted to myeloablative conditioning.
And I think a follow-up to that is more a question about what component of the immune system or the patient's immune system is able to reject the graft. Your thoughts on that?
Well, I would say indeed, as Jen thought and said, it's the T cells. What I just wonder, so in the patient that we followed here in Leuven, this was a very gradual decrease in whole blood chimerism at the myeloid level, but with sustained T cell donor chimerism. So I don't know what happened. I also sometimes think that some trigger may provoke this kind of rejection, as we know from CMV infection, but I think maybe potentially other viral infections like adenovirus could maybe be playing a role. And I also do think that it's important that we look at bone marrow and that we do bone marrow lineage chimerism as well in these patients to learn more what is actually causing it. But as you could see in the graph, there was a very rapid drop from 100% donor to 30%, and at that time the inflammation rose, and I think at that point the graft is lost.
Thank you.
And maybe just to jump in quickly, the other thing that happens, particularly early after transplant, is sometimes you're actually missing the T cell chimerism data because they've gotten serotherapy, they're densely lymphopenic for the first 30, 60 days, maybe even more after transplant. And so you're assessing whole blood or myeloid, but you're actually not seeing what's happening with the T cell chimerism. And that's actually going to be a limitation to the data that even exists to date, is that we probably don't actually know the T cell chimerism for all of these transplants and the kinetics of it early after transplant. But which is, again, the serotherapy is probably needed, but that's one of the dangers of proximal serotherapy, is that you're not going to see what's happening with the T cells. Although I agree in a way with what Isabel is saying, maybe we should go to the marrow and do lineage chimerism in the marrow to try to get a better sense, histologically and then by chimerism of what is going on with the graft versus host.
Thank you. Dr. Metz, a question for you again. The data that you just showed, you mentioned the 6 adenoviral reactivations. Were these just detected by PCR, or were they truly symptomatic? And if so, what are the presentations that you see with adenovirus in this population?
So most of them were symptomatic. So what can you see? You can see all sorts of things with adenovirus, of course. Post-transplant, it can be a simple gastrointestinal manifestation with colitis or ileitis, but it can also go all the way to fever, with skin rashes, with hepatitis. So you can have systemic, very severe disease when the adenovirus is also, if you can detect it by high logs via PCR in the blood, it usually has system manifestations with fever and sometimes also graft suppression.
Correct. And did you see any HHV6 or CMV reactivations?
CMV reactivations, there were a few, I think 2 or 3. HHV6, we had one in our patient, which was relatively well and easily controlled, but there was no more mentioning of HHV6.
Thank you. Dr. Metz, another question for you. If the data that you showed and what's well known is that, pure red cell aplasia is a phenotype for DATA2. And so this is a general question that when people are seeing patients which have a Diamond-Blackfan-like phenotype and negative testing for that, including things like GATA1, how important is it to test for DATA2 in the absence of the inflammatory phenotypic features?
Well, I would say it's crucial. There has been, so you could try to discriminate it by actually measuring ADA1 levels. That could help you discriminate Diamond-Blackfan anemia from ADA2 deficiency. But of course, the genetic testing or the ADA2 enzyme testing would help you. There's been one paper, I don't remember who the first author was, maybe you, Jen, you remember, but actually, in a large cohort of Diamond-Blackfan anemia phenotypically diagnosed patients, there were only, I think, 9% of the patients that were found to have, I don't remember exactly, I think 9% of the entire group was found to have ADA2 deficiency. So it's a small proportion, but it's important to make the differential diagnosis, because otherwise you end up treating the patient with heaps of steroids and you don't get an effect on the phenotype.
Excellent. So Dr. Kanakri, just another question for you. There is description of autoimmune phenomena in the post-transplant period, in these patients. And how would you recommend that, provide a screen for it and treatment options?
Well, I guess, my question would be specifically what autoimmune phenomenon, because I think they all require different approaches, and some, like the cytopenias, are really T-cell mediated, what becomes alloimmune phenomenon, and then there are others that maybe are not so clearly T-cell mediated. So that's sort of a broad and in a way a difficult question. But often related to ongoing mixed chimerism. And so the general approach, regardless of the underlying manifestation, should be to try to achieve 100% donor chimerism across all lineages. And I would expect that then in that setting, the autoimmunity would go away. And so we often try to withdraw immunosuppression earlier to try to get the chimerism to shift to 100% donor. I don't know that I have a better answer than that over such a broad question, but
no, that's excellent. Thank you. And Dr. Metz, the slide that you showed on GVHD prophylaxis, it was very variable. Is there something that you think should be protocolized, and what would be your preference? Sorry, Dr. Metz, you're on mute.
It's very difficult. I like a lot the cyclosporin with MMF post-transplant. And in haplo settings, I also really like to use the post-transplant cyclophosphamide with cyclosporin and MMF. But it seems like here it feels like the methotrexate group is doing better. But again, there's many other variables there with the donor source, etc., and the conditioning regimen. But I do feel that it could play a role, especially if like Jen says, the crucial role post-transplant in going to graft rejection. I do think it could play a role, the GVHD prophylaxis regimen. But we will do further analysis to try and dig something and dig something out of these data that we can really use for the future and that we can build on.
I think we have time for one more question. And, so Jennifer in her talk said that she prefers peripheral blood graft over bone marrow. Your data shows there was more bone marrow used than peripheral blood. What is your stance on this, Dr. Metz?
Well, I think everything depends also on the conditioning regimen and on the donor you are using. And I prefer with the conditioning regimen that I usually use, the triosulfan, fludarabine, and alemtuzumab, I prefer PBSCs by far. It gives better sustained engraftment, in my opinion. So I joined Jan in this comment.
That's good to have a consensus. Last question, Dr. Metz. This is from Ariane Soldatos. Has anyone in your cohort had a stroke during or after transplant?
So only one patient, and actually that was the patient that I first transplanted. He had a pineal gland hemorrhage. I think it was day 40. At the time, he was still thrombocytopenic. He had 14,000 platelets, but that was the only patient from the entire cohort.
Excellent. Well, really, I take this opportunity to thank the both of you for doing such an excellent presentation on a topic that's clearly evolving as we speak. A lot of this is going to help the general community, understand transplant strategies, and I'm really grateful, and thank you for your time.